Welcome to the deep dive. Today we're getting into, well, the very foundation of how your body moves and flows. We're talking about the involuntary muscle systems and the incredible plumbing of our cardiovascular and lymphatic networks. And we are pulling everything from a single, dense anatomical source. Our mission here isn't just to read you a textbook, it's to help you convert these, really complex descriptions, the cell shapes, the layers, into mental blueprints you could actually use.
It's a huge architectural challenge. I mean, we're focused on the two main involuntary powerhouses, smooth muscle and cardiac muscle. And the systems they drive are just vast. To
Yeah.
give you a sense of scale, the total length of your vascular network, if you laid it all out, is about twice the circumference of the Earth.
That's an incredible fact. And when you think about that immense network, it all comes down to the smallest component, this fundamental motor, the smooth muscle cell. So what makes it different? Why do we call it smooth?
It's really about what you don't see under the microscope. The contractile proteins, actin and myosin, they aren't arranged in those neat, regular units you see in skeletal muscle, those sarcomeres.
The striations.
The stripes. Exactly. No stripes. It looks smooth, unstriated, and of course it all works without you ever having to think about it.
Okay, so for building that mental blueprint, what should we picture for a typical smooth muscle cell? What's the shape?
Think of a spindle,
Mm.
or maybe a cigar. They're pretty small, usually. But in something like a pregnant uterus, they can get up to 500 micrometers long, and they have a single nucleus right in the center.
Okay.
And here's the key visual cue. When that cell contracts, the nucleus twists up. It often forms this really distinctive corkscrew shape. And they're packed together in this very efficient way, sort of parallel and staggered. So the wide middle of one cell is right next to the tapered end of its neighbor. It's all about efficient force transfer.
Which lets them do those three big jobs, right?
Yeah.
Regulating diameter, propelling.
Regulating diameter in blood vessels, propelling contents along in the gut, or, completely expelling contents, like in the bladder.
So if you take away the sarcomere, that linear engine from skeletal muscle, what's the mechanism that powers the smooth muscle cell? And why is that different structure actually better for certain things?
That's the real aha detail. Instead of a straight line, the actin and myosin filaments form this sort of oblique three-dimensional lattice. It's anchored to these things called dense bodies inside the cell and dense plaques on the membrane. But what's really fascinating, and this is the key, is the ratio of proteins. Smooth muscle has about 8 times more actin relative to myosin than striated muscle does.
8 times more. What does that functionally allow it to do?
It's all about shortening.
Yeah.
It unlocks this incredible ability to shorten. Because you have so much actin, the filaments can slide a really long way. The tissue can contract by more than 80% of its resting length.
80%. Wow.
Yeah, compare that to skeletal muscle, which is limited to about 30%. Think about the urinary bladder. It has to go from holding hundreds of milliliters to being completely empty. That's only possible because of that extreme shortening capacity.
And what's the trigger for that action? It's still calcium, but the regulatory protein can't be troponin, can it?
Absolutely correct. It's not troponin. In smooth muscle, the calcium binds to a different protein called calmodulin. This calcium-calmodulin complex then activates an enzyme, myosin light chain kinase, and that kicks off the contraction.
So it's a slower, more indirect process.
It is inherently slow, but that's the trade-off. It allows the muscle to maintain tension for incredibly long periods. I'm talking hours or even days with very, very little energy use.
That makes sense. That slow, enduring contraction, it brings us right to the global map of circulation. How does that force translate into the body's entire plumbing system?
Well, the plumbing all centers on the heart, obviously. It's the pump. And we classify vessels simply by direction. Arteries carry blood away from the heart, and veins bring it back. And that system is built on 2 closed loops. You've got the low-pressure pulmonary circulation for gas exchange in the lungs, and the high-pressure systemic circulation that serves, well, everywhere else. Functionally, it's amazing how the vascular tree is differentiated. The aorta is huge, maybe 30 millimeters across, but it branches into about 4 million tiny arterioles. And that branching dramatically increases the total cross-sectional area.
So you classify them by their job, not just their size. Let's walk through those 4 functional classes.
Right, it's logical. First, you have the conducting and distributing vessels. These are your big elastic arteries, like the aorta and the muscular arteries. They handle the bulk flow. Second, the resistance vessels. These are mainly the small arteries and arterioles. They're supramuscular, and they're responsible for the largest drop in blood pressure. They're like the control valves for local blood flow.
And that's where the regulation really happens.
That's where it happens. Third are the exchange vessels. the capillaries, sinusoids, and small venules. This is where the real work gets done, fluid and solutes moving in and out of the blood. And finally, you have the capacitance vessels, the veins. They have thin, really distensible walls, and they act as the body's reservoir, holding the vast majority of your blood at any given time, even though they operate at super low pressures.
And we should probably mention those two specialized circulations that break the normal pattern.
Yes, good point. You've got the venous portal system, where a capillary bed is sandwiched between two veins. The classic example is in the gut, where blood goes to the liver first. And then there's the renal glomeruli in the kidney, where a capillary bed sits between two arterioles. This is all about maintaining the high pressure needed for filtration.
And running alongside all of this, you've got the lymphatic system, which is like the cleanup crew.
The essential cleanup crew. Lymphatic vessels are these blind-ended tubes that just start in the tissues. They collect all the excess fluid that leaks out of capillaries, about 8 liters a day, and return it to the big veins in your neck. Keeps everything in balance.
Let's zoom in on the vessel walls themselves. For anything bigger than a capillary, there's this fundamental 3-layer design, the tunicae. What's going on in those layers?
Okay, so from the inside out. First is the tunica intima. It's the innermost layer, lined by a single continuous layer of endothelial cells.
And these aren't just passive liner cells, are they?
Not at all. They are incredibly active. They regulate blood flow. They're critical for clotting. They make both pro and anti-clotting factors.
Yeah.
And they have these things called Weibel-Palade bodies that store factors for inflammation. They're major players.
Got it. What's next?
Next is the tunica media, the middle layer. It's thickest in arteries, and it's mostly smooth muscle with elastic fibers and collagen. This is the strength and contractility layer.
And the outside?
The outside is the tunica adventitia. It's a connective tissue coat. And in big vessels, it contains its own blood supply, the vasa vasorum vessels of the vessels, and its own nerves, the nervi vasorum, for controlling the muscle tone.
And the arteries are split into 2 main types based on what's in that media layer.
Precisely. First, the big ones, the large elastic arteries like the aorta. Their media is just packed with alternating sheets of elastin, about 52 layers of it.
So they're built to stretch.
Exactly. They stretch under systolic pressure and then recoil during diastole. It's what keeps blood flowing smoothly downstream. Then you have the muscular arteries, the distributing vessels. Here, the media is dominated by smooth muscle, making up about 75% of its mass. And the telltale sign is a very distinct wavy line called the internal elastic lamina between the intima and the media.
Which brings us right to the gatekeepers of the capillary beds, the resistance vessels, the arterioles.
Yes, the arterioles. They're anatomically distinct because their walls are incredibly muscular for their size. Wall thickness can be almost half their outer radius.
And they have a lot of nerve connections.
Densely innervated by sympathetic fibers. This gives the body extremely precise, local control over blood flow through vasoconstriction. This is where you fine-tune everything.
Okay, so once you're past those gates, you hit the exchange zone. And there are 3 types of capillary, right? Based on how leaky they are.
Right. Structure determines function here. Most are continuous endothelium capillaries. Their cells are joined by tight junctions, so they have very low permeability. You find these in the brain, forming the blood-brain barrier.
Makes sense.
Then you have fenestrated endothelium. These cells have little pores or fenestrations that allow for much faster diffusion. You'll see these in places like the kidneys and endocrine glands. And the third, leakiest type, is the sinusoid. These are large, irregular capillaries with actual gaps in their walls. This allows for really intimate contact with the tissue, which is critical in organs like the liver, spleen, and bone marrow.
After the exchange, blood flows into the low-pressure veins. Since the pressure is so low, how does the body get the blood back to the heart, especially from your feet?
That's the challenge. The pressure can be below 5 mmHg. So the 2 crucial mechanisms are the venous valves, which prevent backflow, and the external pressure from surrounding muscles, the so-called muscle pump.
So every time you walk, you're helping pump blood back up.
You absolutely are. And the veins themselves can constrict venoconstriction to help mobilize blood back to the heart when needed. The lymphatic system works in a very similar way, with lots of valves and relying on external compression.
Now, for the ultimate pump, the heart. Cardiac muscle is also striated, like skeletal muscle. But what makes its structure so unique for this nonstop, lifelong job?
Okay, so cardiac muscle cells are striated, yes, but they're branched, and they usually only have 1 or 2 nuclei right in the center. But the real giveaway about their function is their metabolism.
The mitochondria.
The mitochondria. About 35% of the cell's volume is mitochondria. That is an extraordinary density, and it just screams that this tissue has a continuous, high-energy aerobic metabolism. It needs constant oxygen.
And Because the cells are separate and branched, how does the heart get them all to contract in perfect synchrony? What's the connecting piece?
The connecting piece is the intercalated disc. This is a complex junction that makes sure the whole myocardium acts as one coordinated unit, or syncytium. It has two key parts. The transverse portions have powerful mechanical junctions, desmosomes, that transmit the force of contraction from one cell to the next.
Okay, so that's the mechanical link. What about the electrical?
That's the lateral portions. They are packed with gap junctions. These are basically low-resistance channels that let the electrical impulse, the action potential, pass directly and rapidly from one cell to the next, is what coordinates the heartbeat.
And the actual mechanism of contraction is also unique. It's called calcium-induced calcium release.
Correct. The action potential in the heart is really long. It has this plateau phase caused by calcium flowing into the cell.
Yeah.
Now, this initial trickle of calcium is the trigger. It causes a massive release of stored calcium from the sarcoplasmic reticulum inside the cell. The system uses these wide T-tubules and a special junction called a diode to get that signal deep into the cell quickly.
And this reliance on calcium coming in from the outside is what leads to the staircase response, right?
That's it, exactly. If you increase the heart rate, there's less time for the cell to pump that calcium back out. So more calcium gets stored for the next beat, which leads to a stronger contraction. It's an intrinsic way for the heart to adjust its own strength.
It's an incredible system, but it's also fragile. Let's finish up by connecting this anatomy to where things can go wrong. Let's start with the two big arterial diseases.
Right, and people often mix them up, atherosclerosis and arteriosclerosis. Atherosclerosis is a focal inflammatory disease. It targets the tunica intima, that inner layer of medium and large arteries.
And it starts with cholesterol?
It starts with oxidized LDL, the bad cholesterol. Macrophages eat it up, they become these lipid-filled foam cells, and that's the beginning of a plaque that narrows the artery. This is what leads to heart attacks and strokes.
And arteriosclerosis.
Arteriosclerosis is different. It's a more general hardening of the arteries, a loss of compliance. It happens when smooth muscle gets replaced with collagen over time. It's sped up by age and high blood pressure, and it's a big reason why systolic blood pressure tends to rise as we get older.
Moving over to the venous side, the weak points are the valves.
That's the key vulnerability. The big one is deep vein thrombosis, or DVT, which often starts right at the valves in the deep veins of the calf. If that clot breaks off, it can travel to the lungs and cause a fatal pulmonary embolus.
And also see varicose veins.
Right, which is basically valve failure combined with chronic high pressure in the veins of the lower limbs. That's what causes those dilated, twisted vessels.
And finally, there's that amazing detail about smooth muscle tone going into overdrive, like in Raynaud's phenomenon.
It's a perfect example of molecular anatomy. Raynaud's is this exaggerated vasoconstriction in response to cold. And the underlying issue is that alpha-2C adrenergic receptors move from inside the cell to the cell membrane.
So they become way more sensitive.
Dramatically more sensitive to the noradrenaline released by nerves. And there's even evidence that estrogen might play a role in this, which could be why it's more common in premenopausal women.
And smooth muscle's ability to change its whole job description can also be a problem in disease.
It really can. Normally, it's a contractile cell. But in things like chronic asthma or pulmonary hypertension, it can switch to a secretory phenotype. It starts dividing and remodeling the tissue, which just thickens the vessel walls and makes the whole condition worse. So if we tie it all together, you really have the foundational blueprint now. From that unique, slow contraction of smooth muscle that allows for 80% shortening, to the three-layered design of arteries that handles a pulse wave, all the way to the high-energy, perfectly coupled efficiency of cardiac muscle.
So what does this all mean for you? Well, understanding these involuntary systems really highlights the incredibly fine, dynamic balance that maintains life. The anatomy here isn't static. It's a system constantly adapting to strain. So consider just how finely tuned your body's plumbing really is, and how a tiny structural change, a leaky venous valve, the movement of a single receptor, or a little lipid buildup in the intima can cascade into a serious systemic disease. The integrity of these tissues is truly the basis of clinical practice. Thank you for joining us for this deep dive into foundational anatomy. We hope you feel thoroughly informed.